is Dr. Chad Creer, the Medical Director of the Wyss Clinic. Wyss stands for nature. The Wyss Clinic's philosophy is, by finding and removing the barriers to self-healing, such as a poor diet or unhealthy habits, naturopathic physicians can nurture the process of allowing the body to seek self-healing. Dr. Creer's topic this evening is knowing your risk for heart attack and stroke. Dr. Creer is a board-certified doctor of naturopathic medicine. He earned his degree from Baxter University in Seattle, Washington. He also holds a Doctor of Chiropractic degree from Parker College in Dallas, and also holds a degree in anatomy. Dr. Creer is a native of Great Bend. He has been a professor, lecturer, researcher, and practitioner who is now very happy to be making his home as the medical director at the Wyss Clinic. So we are very, very pleased and very appreciative that he has come to speak to us tonight. And we appreciate you coming. All right.
Howdy. Stuck in the basement on the nice weather day, huh? Yeah. Should have had it out at the gazebo somewhere. Okay, we're going to talk about risk factors for heart disease and stroke. And some of these factors will be something you've heard of before. And then we hope to talk to you about some new factors that you can have measured in your blood that can give you a better clue as to what could be happening in your body. So everybody's probably had a lipid test at some point in their life. Raise your hand if you've ever had a cholesterol measurement. It's pretty much everybody. So when we talk about routine lipid measurements, we're talking about cholesterol, LDL, HDL, VLDL, triglycerides. Those are, if you go to your primary care doctor and maybe once a year, every 6 months, they run a lipid test, those would be the things that would get measured. So who knows that most of the time when you go to your doctor and they measure an LDL, which is considered the bad cholesterol, that it's just based on a mathematical number and it's not a true number. Did you know that? So some people know that. Yep. So sometimes you can go and it'll say direct, sometimes it'll say indirect. If it's indirect, then it's based on math, and sometimes that can lie to us. Well, let's look at traditional lipid panels. We know cholesterol, kind of telling everybody we want it under 200. HDL is your good cholesterol. It can be a little, women and men are different. They give different reference values, but for the most part, we say above 50 or 60. LDL cholesterol, historically, we always want it under 130. Now they'll tell you if you've had a family history of heart disease or you've had a heart attack yourself, try to keep that under 100. And then triglycerides, we try to keep those under 150. And we'll go into more detail about all those. So those were all the conventional risk factors that we think of. Cholesterol, and the good and the bad cholesterol, LDL and HDL. Triglycerides, VLDL that carries your triglycerides. But what are some of the other, factors that everybody kind of knows of, and that can relate to cardiovascular disease that don't relate to our cholesterol, and that's cigarette smoking. So that can really oxidize our blood vessels and lead to problems. High blood pressure that puts too much pressure on the pipes and makes the pipes weak in our body. Having low HDL. HDL is what cleans out our arteries, so if it's low, you don't clean out your arteries very well. Family history. So if you have a relative who was a guy and they passed away before the age of 55 or had a heart attack or stroke before the age of 55, and if they passed away it was heart related before the age of 55, then that's a risk factor for you. If you had a female first degree relative who had heart disease before the age of 65, that's a risk factor for you. Just being above 44 is a risk factor if you're a guy, and women get 10 years difference on us. So if you're above 54, that is a risk factor. Why? The longer we live, the more likely we are to have a heart attack or stroke, right? Something's got to get us. So, clinical coronary heart disease, if you've had heart disease, if you've had carotid artery problems, any kind of peripheral vascular disease, that puts you at increased risk for having another heart attack or stroke. Cholesterol is what we conventionally have looked at, and you've probably all heard, cholesterol does other things besides cause heart disease. So when we think about cholesterol, is cholesterol really a real bad guy? Probably not necessarily. Cholesterol helps regulate our membrane fluidity, so it's responsible for the outer part of all of our cells, and that outer part is how our cells communicate with each other. So you need cholesterol to keep your cells together. Cholesterol is found in our brain, and it helps to insulate our nervous system. So 8% of our brain is cholesterol. About 50 to 60% of our brain is fat, and 8% of that should be cholesterol. Cholesterol insulates the nerves or the wires, so it helps our wires work good in our body. She just had mentioned that vitamin D, we know, does a lot of good things for us. Well, it's made from cholesterol in our body. We can get it from animal foods in the sun, but if you want to get it from the sun, you have to have cholesterol, because that's what the sun uses to make vitamin D. It makes all of our hormones, so it makes our male hormones, testosterone, DHEA. It also makes all the female hormones, estrogen, progesterone, all those good things. So we're going to see that after menopause or after age 50 in guys, you definitely don't want to get your cholesterol too low, or it can drive your energy levels down, things of that sort. Cholesterol is needed for fat absorption. So we get our fat-soluble vitamins through the diet. We need cholesterol to help us absorb those. What are the fat-soluble vitamins? Who can name 4 of them? Kind of like ADIC, but ADIC, A, D, E, and K. Yep. So you need cholesterol to help you absorb vitamin A, vitamin D, vitamin E, and vitamin K. And those guys are all real important. And then cholesterol is an antioxidant. So cholesterol helps prevent cell damage by fighting off oxidation. I say it puts out fires. So if there's oxidation or inflammation in our body, our liver will send that cholesterol out into our system to put the fires out. So a lot of times heart disease is nothing more than inflammation, and it's our body's repair mechanisms have gone awry, and sometimes they go too far and we put too much cholesterol out, but it's usually there to put the fires out most of the time. So lower cholesterol is always better, right? Or wrong? Okay. Well, when they looked at about 500,000 people over about 15 years, we looked at the risk of death from these 3 things. When they looked at glucose levels, cholesterol levels, and triglyceride levels. And they found that high cholesterol was associated with coronary heart disease in both men and women under 50. So if you were under 50 and you had high cholesterol, that high cholesterol increased your risk of developing heart disease. Then they looked at those who were over 50. And if you had low cholesterol and you were over 50, it increased your risk of all causes of death. So increased your risk of death through heart disease, cancer, liver disease, and mental illness. So if you're under 50, work on it a little harder. If you're over 50, you don't want to get that cholesterol too low. Remember that high cholesterol is absent in almost 50% of everyone who will ever have a heart attack or stroke. So 50% of people who go to the ER with a heart attack symptom or stroke symptoms, their lipids are completely normal. Statins and cholesterol. Statins are a medicine that can lower our cholesterol. And this was when they looked at this trial, they were looking at how LDL lowers, how we can lower LDL with just using medication alone. And what they've seen is about a 25 to 30% relative risk reduction in cardiovascular events when you're able to lower your LDL by using a statin. So 25 to 30% relative risk reduction. That means the number needed to treat to prevent one person from having cardiovascular disease, you need to treat 30 patients. So if we had 30 people with high cholesterol, if we treated all of them, one of them would actually do better as far as their heart symptoms went by being treated. So that means 29 out of those 30 would not. So even despite statin therapy, a substantial number of patients will still have a cardiovascular disease event. So even if you're on your statin, may not protect you like you think it might. So what do we do about this? We look at some newer tests now. Because how do we, as a clinician, address the fact that only about 25% of people are going to be helped? 25% of those who have high cholesterol are going to prevent their risk for heart attack or stroke by being on a statin. So 70 to 75% will not protect themselves. So we use tests that are not usually found on routine lipid panel, and there's lots of different tests out there. So these newer risk markers help us to help the other 70 to 75% of patients. We use a Boston heart test. There's all kinds of different tests that are out there on the market now. You may see different names, but a lot of them are combining all of these beneficial circulation tests into one blood draw or into one test. So, you know, the one we're using is called Boston Heart. We send it to Boston, to the heart hospital, and they still measure all the conventional lipids like total cholesterol, LDL, but they measure a lot of different other things as well, and we're going to talk about each of these different things that you see there, and we're going to talk about what all those mean. So when you order a Boston Heart test, you get all that information. We get all these different lipid ratios information. We get all these markers of inflammation as far as inflammation information. Then we get a look at what blood sugars, insulin, things of that sort, and we also get a look at some of the things that a pre-diabetic patient may have. And we're going to talk about all of those in detail. We also look at the genes, so we can predict your risk factor for heart disease, just looking at the genes now. Look at your risk factor for clotting, so there's different clotting genes that we can look at. And then we look at cholesterol balance testing, and that gives us an idea of if your cholesterol is high, where is it actually coming from. So we're going to start off with that test. When we do a Boston Heart test, we do a cholesterol balance test, and it measures markers of cholesterol synthesis, so meaning markers showing that your body is producing cholesterol. And then it measures markers of cholesterol absorption, meaning that you're getting it from your diet, absorbing it in your gut, and putting it in your bloodstream. So this helps us decide, are your elevated cholesterol, elevated lipids coming from mostly your diet, or are they coming from your liver, your own production, or are they coming from both? And that's important because that helps us address how to treat that. So all individuals are different when it comes to this, and so we know some people may synthesize more cholesterol, some people may absorb more, some people may not clear cholesterol out of their system, so they have poor clearance of cholesterol. It's important to know which one of those three, or if you're a combination of all three, because it dictates therapeutics that we can go with. This is just an example of what a cholesterol balance test would look like. When we order that, they give us production markers, and we see two types of cholesterol. These only come from our liver, so that tells us if we're making the cholesterol in our liver, versus absorption markers. These types of cholesterol only come from our diet. So we can look over beside it, and it'll say, okay, you're either absorbing a lot, or you're producing a lot, or you're doing both. In this person's case, they were absorbing a lot of cholesterol, and so we would call them an overabsorber, and we'd want to treat them. Dietary would be a big component, and maybe using things that block their absorption of cholesterol in the gut, or making sure they had a real high fiber diet every time they ate anything with cholesterol. Where do you get cholesterol?
Trans fat.
Yeah, you get it only comes from animal foods. So it has to be some kind of animal-based product to get cholesterol. So if we want to do something that blocks your absorption of cholesterol, we wouldn't have to do it unless you're eating an animal food. So let's say you just eat oatmeal for breakfast. Well, you wouldn't want to do anything that blocked your cholesterol in, because you're probably not getting any unless you put milk or something in with the oatmeal. Okay? So cholesterol balance, it's good to know because it helps us decide how we're going to treat patients. So patients who are overproducers, when we talk about nutrients, If it's their liver that's overproducing things, then as far as nutrients go, I'm not going to talk a lot about medicines tonight, but as far as nutrients go, like red yeast rice or niacin, those would be two beneficial things that someone who's an overproducer could use to lower their cholesterol. If you're an overabsorber, then you're going to do better with the plant sterols, the mimickers of cholesterol that plants make. They help to prevent the absorption of animal cholesterol in our diet. That's why it's important, eat your plant foods with your animal foods, and you'll keep your fats down if you're one of those absorbers. So when we look at overall, cholesterol can come from our liver, or it can come from our diet. Either way, it gets into our bloodstream, and then our body has to decide what to do with it. If you can see this, we're looking at 3 different treatment options based on where the cholesterol is coming from. So if we see that you have a lot of the dietary factors for the cholesterol that come from the diet, then we're going to say you're an overabsorber of cholesterol. And if you're an overabsorber, then we want you to do things that cut down the absorption of cholesterol when you eat. And that's making sure you have lots of fiber. You can buy plant sterols and take those with meals. You want to make sure your bowels are moving. So if you're constipated, that all that food sets in your gut for longer periods of time, gives you a longer period of time to absorb that cholesterol. So you want to make sure your bowels are moving. Water helps to flush the bowels so that you're not absorbing so much cholesterol. And then watching your animal food intake. If you know you're a high cholesterol absorber, you're one who's going to do better on a vegetarian type diet or low animal product diet. If we look here and you're an overproducer of cholesterol, meaning that it's mostly coming from your liver, then that's when we want to do things that talk to the genes of your liver. And so it's more of a genetic trait when you're an overproducer, and we would use things like niacin that can talk to the genes, and then use things that support your liver. We use, turmeric would be important, milk thistle, things of that sort. If you're one of those, when we look on your test and it looks like, okay, they have high cholesterol, but they don't have any of the production markers and they don't have any of the absorption markers, what the heck's going on here? Those markers may be low or normal. And then that tells us you have a receptor clearance issue, meaning that your liver's receptors don't clear out the cholesterol out of your blood like they should. So that cholesterol at some point should be cleared from your system. If you're not clearing it out, then that's when we talk about bile acids, sequestrants, and a nutrient called N-acetylcysteine. So that's where it can get hairy, because you could say, well, gosh, I've tried all these things for my cholesterol, nothing worked. Well, you got to know where your cholesterol is coming from. So we can specifically target what the area in your body that needs targeted so we can bring that cholesterol down. Okay, lipoprotein particles in cholesterol. So cholesterol, we've normally, conventionally talked about cholesterol as 2 types, either HDL, which is the good guy, or LDL, that they call the bad guy. I think of the liver in our body kind of like being the warehouse. So my dad was a UPS man, so I think the liver as the UPS warehouse, right? And you've got trucks. You've got LDL, and that's a truck that will take packages from the warehouse out onto the highways, out onto the circulation. And then you've got trucks that go out and pick up the packages and bring them back to the warehouse, and that's HDL. So depending on what your liver decides to make, you could have a big mess if you have a lot of LDL that's delivering packages and not very much HDL that ever brings those packages back. Okay? When we talk about HDL cholesterol and LDL cholesterol, it's a misnomer. What we've historically been measuring is the cholesterol found inside of these things, when we actually should have been measuring the lipoprotein particles. They're the particles that carry the cholesterol around. We've been measuring the cholesterol instead of measuring the trucks that are carrying those packages. So it's the particles that carry the cholesterol throughout the body. It's not the cholesterol within them that are responsible for creating plaque in our arteries. And just remember, when we look at cholesterol, it's only one out of 30 independent risk factors that we know of for heart disease. So there's 29 other things that can stand alone independently from cholesterol. Lipoprotein particles, so particles can vary in size, weight, density, all that. Each lipoprotein has subclasses, and these subclasses have different roles in the development of cardiovascular disease. So why is it important to know our lipoprotein number? So we know that the more particles or the more trucks you have in your highway system, the more likely you are to have a cardiovascular disease event. So as these particle counts go up, the probability that those particles will get into the muscular layer of our arteries rises. So what happens is those things are driving down the highway and they crash into the ditches. They get into the muscle layer of our arteries. And the more of them that are on the highway, the more they're going to crash into the ditches. And the more likely they are to create trauma in our blood vessel, the more likely they are to create a pileup of cholesterol particles, and that leads to plaque. So we don't want to have a lot of those guys traveling down the highway. When we look at LDL particle number, it's a measure of the number of lipoprotein particles. It's a measure of the number of the particles, but not the cholesterol within them. And we'll show you a picture here in a minute to make sense of this. So one of the most important tests you can have is, we know your total LDL, but there's different types of LDL. There's large and small. It's the small LDL that's creating problems. We know the large LDL is protective, and small LDL is actually harmful. So small dense LDL is smaller, more dense atherogenic LDL trucks. So it's the little Corvettes that weave in and out of traffic and cause wrecks, right? So these guys are a problem. You may also see this labeled pattern B. Pattern B LDL is the same as small LDL. So high levels of this type of LDL increase your risk 2 to 3-fold for having some sort of blood vessel event. Small dense LDL, they're more atherogenic than the large LDL. And why is that? Because they're smaller, so they can be attacked easier, so they can get oxidized easier. Because they're so small, they don't bind to the receptors on the liver very well, so they stay in our circulation longer, so they don't get cleared. And that means they're basically going to stay around longer. When we look at this, if our liver makes these small guys don't stick to our receptors, so they don't come out. So they just keep building up in our circulation. And the more and more they build, the more likely they are to break through the wall of the blood vessel, get into the muscular layer, and create problems. As they get into this layer, we start to form a plaque, and it starts to put pressure on the pipes, and we get less blood flow. And then we run into problems. So that small dense LDL is the real bad guy. Well, let's say that you've been to your doctor and you get tested every year, and every year you find out your cholesterol is normal or it's not too bad, so you're thinking no worries. Well, we know that at least 20%, so 1 out of 5 of us have cholesterol depleted LDL. It means if I look at if this was your LDL particle, and some of us would be completely full of cholesterol, maybe you're one who has just a little bit of cholesterol in each particle. So this means you don't have a lot of cholesterol in each particle, so your cholesterol may look normal, but your particle number, which often doesn't get tested, could be much higher than expected, and so your risk factor could be a lot worse than you think it is. We see this more in people whose triglycerides are high and their HDL are low, but basically what this leads to is about a 40% error in our risk assessment. And this is the picture I'm going to talk about. We got Jerry down here. He's got 125 milligrams of cholesterol in his blood test. And we've got Susan. She's got 125 on her blood test. We got David. His cholesterol is 125. And then Maria, her cholesterol is 125. So all of their cholesterol is the same. And the cholesterol is this little blue shaded area. The particle is the outline of the blue. So we can see that Jerry here, he's only got 1 particle, but it's pretty decently filled with cholesterol. He's got a large particle that's got a little bit of cholesterol, pretty much good cholesterol in it. We got Susan. Who's got more particles, Jerry or Susan? Susan. So who's got more trucks on the highway? Susan. Who's more likely to drive off the road and into the ditch and cause problems? Susan, right? Even though her cholesterol is the same. And then we've got David. Now, this one may be the semi-truck, but David's driving the Corvette, so he's driving crazier. He's got the same number of particles, the same number of cholesterol molecules, but he's driving the Corvette and he's weaving in and out, so who's more likely to drive off the road? David. And then we've got Maria. Uh-oh. I don't know what car she's driving, but she's got a lot of them, right? So they're definitely more likely to crash and burn. So even though they all had the same number of fat or the same number of cholesterol, Maria had the highest number of protein particles that are carrying her cholesterol. So she's at a much greater risk for developing heart disease or stroke than Jerry. But if we just went and looked at the conventional test, their cholesterol all would have showed up the same and their LDL would have all showed up the same. But one of them's at a pretty high risk for developing a heart attack or stroke, and one of them's at a pretty low risk. So these would have been the type A particles and then type B particles. So if we have high LDL, diet and exercise, weight loss, controlling diabetes, when your diabetes is out of control or insulin's out of control, it sends a signal to the genes in the liver to make more cholesterol. And it tells them to make more of the bad cholesterol, not the good stuff. Some things you can think about to lower your small dense LDL, making sure you have enough omega-3 fats. Niacin is really good at lowering small dense LDL. Getting enough fiber if you end up being an absorber, and red yeast rice is something that can be helpful too. Chromium, lipoic acid, things of that sort that help work on your glucose regulation. Okay, apolipoprotein B. Who can say that? That was good. Okay. Apolipoprotein B. So apolipoprotein B, or ApoB, is what you may see it on as a test. It's a protein. It's made in your liver. It can also be made in your gut. So we can make part of our cholesterol particles just in our intestines. It's very atherogenic. It's found on our very low density lipoproteins. It's found on these intermediate, and it's found on LDL. Lipoprotein, it's also found on some other things as well. This ApoB, basically if we measure this ApoB, it tells us the number of bad particles that we have in our bloodstream. So you need this protein to make each bad particle in your bloodstream. So this is a real important number. It's a better number to have measured than your LDL or your cholesterol. Whoops, hit the wrong button. ApoB is a surrogate marker basically for the LDL particles. So the more ApoB you have, the more of those trucks you have in your system. It's high risk if it's greater than 120. So it's a more reliable indicator of cardiovascular disease risk and stroke than is just having your LDL. So you can ask to have an ApoB test measured. Again, all those things that work to lower your cholesterol would help to lower ApoB. We want to talk to the liver and tell it to quit making so much of that particular protein. How about ApoA1? I call it A1 steak sauce. This is the good stuff. So you want to have A1 steak sauce in your blood, okay? Apolipoprotein A1, this is also made in the liver. It's made in your intestines, but it's the protein that makes the good cholesterol. So having this measured actually tells you the amount of protein that you have available to make the good stuff in your liver. So we'll skip that part again. They give you different numbers for male and females, but if you have a low level of this, then that increases your risk for cardiovascular disease. So you want your ApoBs to be low, you want your ApoAs to be high. You want to have more A's than B's. Okay, pretty much on everything, the A's are better. So again, we do know that niacin is one therapy that will raise our ApoA1 concentration on our liver. But one of the big things, if you know you have low HDL, vitamin B5, pantothenic acid, or panathine, is something that helps you make HDL. And the reason is because panathine makes coenzyme A that helps you make ApoA that helps you make HDL. So people with really low HDL can take a lot of vitamin B5 and it can really raise their HDL well. Boston Heart Map, this is where we look at the different subsets of HDL. So sometimes we can get a total HDL and it'll be above 60, which is where we want it, and we think we're in good shape because our total HDL looks so good. I a lot of times see that women with high HDL actually have a higher risk of heart disease because their high HDL is the wrong kind of HDL, and it gives you a false sense of security. I've had a lot of women who've had heart attacks who had very good HDL, and you think they'd be great. I don't see that so much in guys, but you do see that more in women. So HDL is comprised of different subparticles of different sizes. And when we look at the data from all kinds of different major cholesterol studies, what they found is that HDL subpopulations are better predictors of cardiovascular disease risk than just measuring HDL by itself. So we can measure the 5 most common types of HDL, and what it's looking at is the amount of the good A1 steak sauce that's in each type of particle. The more A1 we have, the better. There's different types of HDL. There's alpha 1, alpha 2, 3, 4, and then pre-beta 1. It's the alpha 1s and the alpha 2s that are most important. And they know if we can just raise your ApoA1 1 milligram per deciliter in this alpha HDL, you can decrease your risk for cardiovascular disease by 26%. And it's actually pretty easy to raise that particular kind of HDL, and just by raising that just the baby amount, you decrease your cardiovascular disease risk pretty significantly. So again, what we want big HDL molecules. Why? The bigger they are, the more packages they can pick up out of our circulation, the more packages they can take back to the liver, so they're better at collecting all those boxes and getting them out of our circulation. Increased amounts of this alpha 1 HDL mean that our HDL has matured like it should, and it decreases our cardiovascular risk. We'll look at this here in a minute. Increased amounts of small HDL are associated with increased risk of cardiovascular disease. So just like large LDL is protective, small LDL is bad, large HDL is good, small HDL is bad. When we look, our liver makes this HDL, and it starts with these guys, these pre-betas. These are the babies. Then they can become toddlers, then teenagers, then adults, and then worker adults. So ones who really go out and work. Okay? We don't want to have a lot of these. We want these guys to mature quickly so that they can become workers, gather up all the cholesterol, and take it back to the warehouse. So those guys are really good workers at cleaning the highways. If we have a bunch of these guys, they're not very good workers. They're not going to clean much, and so our highways are going to be littered. Right? So we're going to have lots more plaque if we don't have good levels of those and we have too many of these. Well, what can we do to raise our HDL? I wanted to give a comparison of what vitamin is niacin? B what? 1, 2, take a guess. 3. Yep, vitamin B3. So niacin is vitamin B3. We can look at what 2 different things do with our HDL. Niacin can raise your HDL 20 to 40%. Statins can raise your HDL 2 to 10%. So I'd rather do the niacin. ApoA1 concentration, that A1 steak sauce, niacin can raise that, statins will not. So statins aren't going to tell our liver to make more of the protein that helps us make the good HDL. Alpha 1 particles, niacin can raise your alpha 1 particles, the best kind, the largest HDL, they can raise that up to 115%. Statins can raise it 12 to 36%. Alpha 3 particles, those are the ones that aren't mature, so they're not good workers. Niacin really doesn't have an impact on it, neither do statins. This is where we see something. Pre-beta 1 particles, that's the babies. So niacin dampens it, by about 30%, whereas statins suppress it up to 40%, so a lot more. So they prevent all those babies from being made, so that's why they don't let us make as much HDL. Whereas niacin just kind of says behave a little bit, but it still allows them to be churned out. So if you're looking to raise your HDL to really clear the arteries, niacin is going to be a better option than statins. Lipoprotein A, has anybody had that test measured? So lipoprotein a, it's an atherogenic particle. That means it can create plaque or plugging of the arteries independent of any other risk factors all by itself. It's composed of an LDL particle, and then it's composed of a different protein, not this ApoA1, something different. But elevated levels are an independent risk factor for developing a heart attack, for developing a stroke, for having some sort of stenosis in a vein that you may have had corrected, and for causing blindness, retinal artery occlusion. So just having this, even if everything else is normal, and you have this, you're at increased risk for every single thing related to your heart, basically. This is what I call the silent killer in women. So if you're a woman, you should definitely have that test measured. This is the one I see that most of the time women, this is where you're that 75% where your cholesterol has historically been normal, but this test is not normal, and this is the one that ends up getting you. So that one's definitely worth having treated. When you have that high, of course, we want to make sure you don't have any other bad things high as well. So we want to make sure we treat everything, but main goal is to try to get that lipoprotein a below 20. I see it routinely on women, just never been measured. They come in, it's 120, 130, it's just out of control. And if that guy's in there, it's like a fireball in your arteries. So it just can create plaque instantly. So you want to get that guy down. The only therapy that we know of, either drug or non-drug, is niacin. We don't know of any other primary therapy. Niacin at 2,000 milligrams lowers lipoprotein a by 24%. That's if you take a sustained release, which tends to be a safer form of niacin that doesn't cause as much flushing because it's released over a period of time. Niacin is one of those vitamins in high doses that can make you feel like you've been stung by a hornet's nest. You can get red, hot, itchy, like you're having an allergic reaction. But it's actually the immediate release niacin that works a little better for this. And again, when you're doing something to lower your lipoprotein a, all we know of is a nutrient. We don't have any drug therapy for this. When you're talking about nutrients, they don't work immediately, but it will work within about 3 months. But lipoprotein a, having that elevated is from your genetics. It's from your genes in your liver. Once it's up, it's always going to be up unless you do something to keep it down. You can't put it down and let it stay there, and if you come off the niacin, it'll go right back up. So other things we can do, we do know that in some women after menopause, as estrogen drops, the lipoprotein a goes up. It's probably because you're not using as much cholesterol and lipids and things to make your estrogens anymore, and so that's why, that's when our cholesterols can start to go up. The other thing that may lower it is willow bark, but I haven't seen that work quite as well, but there are some studies on that. Statins don't do anything. Diet and exercise have no effect on lipoprotein a, so it is more of a genetic factor. Inflammatory markers, high sensitivity CRP, that's the one that's also called cardiac CRP. Has anybody had that measured? That's becoming more common. So it's a measure of inflammation. We know that hardening or plaquing in the arteries isn't just because of lipids. It's also because of some kind of low-grade inflammation in our arteries. Again, why does cholesterol go out there in the first place? To try to put out fires. So if we've got a lot of fires in our arteries, then that's when that cholesterol starts to go up. So we see that this CRP is found in the smooth muscle of our arteries, and when it's high, it means that a lot of things have taken place to create inflammation in your arteries. So this is a great test to tell you if your arteries are on fire, basically. And if they're on fire, we want to do things to put out that fire. When you have high CRP, your risk of cardiac death is double. Patients in the top quarter have about a 6-fold increase of heart disease and stroke than those in the lower quarter. So a CRP is generally, you want to have it under 1. Anything above 1 is considered high. If your CRP is above 4.2, you're at a 6-fold increase for stroke or heart attack. Again, we do things, turmeric, we want to repair damaged arteries, make sure that your insulin's normal, things of that sort. Clotting factors, this is another inflammatory marker that you can have measured. This is called fibrinogen. So fibrinogen is also called factor 1. It's one of the protein enzymes that's involved in the clotting cascade. Fibrinogen basically helps us form a blood clot. So it's one of the steps in forming blood clots. If you have elevated levels of this, we can assume there's probably inflammation in your arteries. For every 100 milligram increase above 300 with this, there's about a 2-fold increase for developing heart disease or stroke. So if your number's under 300, you're okay. If it's 300, you're at a 1 to 2-fold increased risk for heart disease. For every 100 points after that, it goes up about 2-fold. So we want to make sure we keep that down, and that's something that's important to measure. To me, one of the most significant tests you can have measured or asked to have measured is LpPLA₂, lipoprotein phospholipase A2. Probably, this test has been around, I don't know how many years. We started to see it about 3 years ago, and I've been using it since that time. To me, it's every guy at least over 44 and every woman over 54 should have that test. So LpPLA₂, it's an enzyme. It's produced by our white blood cells, and it's used to break down plaque. If your white blood cells are producing a lot of this enzyme, you can assume you have a lot of plaque in your body, and your white blood cells are really trying to break that down. It's basically associated with atherosclerosis. High is greater than 235, so it's an independent risk factor. Even if everything else is okay and you have this, we know you're plaquing because your white blood cells don't lie to us. 2-fold increased risk for coronary artery disease, 2-fold increased risk for stroke, just if it's at the high end, at the very high end of normal. If this is high along with CRP, so those two are great to measure together, you have an 11-fold increased risk for having a stroke or heart disease. So very important having those two tests measured. I had well, I'll talk about it here in a minute. What can you do about that? Again, most things that lower the lipids or raise our HDL or lower lipo-A, all those things tend to help us get rid of this LpPLA₂. The biggest thing I've used is chelation to try to, if somebody's got really high LpPLA₂, we do something called IV chelation, where you put in some chelating agent into the blood vessel to try to decrease oxidation. And decreasing that oxidation helps the antioxidants repair the blood vessels, helps to decrease the plaque. Again, anti-inflammatories can be good things. Vitamin C that strengthens the blood vessels can be real important for this. Mariva is just a natural anti-inflammatory. And then something at the bottom that helps to strengthen the heart, the blood vessels, are these cardiac glycosaminoglycans. They're something that they've really shown can really give support to your arteries. And we think if you have strong, healthy arteries, there's no reason for your liver to go out there and try to support them with cholesterol. But again, those things can be really helpful. I have a guy whose mom probably, she saw my partner before me, and then me, and some of the doctors I've worked with in the past. She started seeing us in, well, probably about age 60. She refused to quit smoking. So she smoked one after the other and just would not stop no matter what we told her. But she came and got a chelation once a week for about 30 years and kept her heart going. But she was one who I bet had high LpPLA₂, because now we see her son who refuses to quit smoking. He doesn't smoke quite as much as mom, but still smokes all the time. And his LpPLA₂ was off the chart when we first measured it. If he does chelation once a week, it stays down. So he's living on chelation. It is. You think it would be cheaper to give up the cigarettes. This is just a cross-section of what can happen. If this is the tube, the pipe, or artery, we're taking a cross-section of that. This would be the hollow part where all the blood flows. This would be the inner lining, and then down here is more of the muscular layer. LDL, as it's traveling through, if it gets oxidized, it starts to stick together. And as it gets oxidized, what happens is as it's sticking together, it sends off a warning signal to our white blood cells that something's happening. Our white blood cells then start to try to eat all that oxidized cholesterol, but they send out signals, these inflammatory molecules. Inflammation starts to rise, and as all that inflammation starts to happen, it causes these muscles to start to move up towards the hollow part of the artery, and pretty soon it's taking up the hollow part of the artery and blocking our blood flow. So that's really how we can start to develop plaque in our arteries. This gives us a representation of what can happen with weakened vessels. This is just one nutrient. They've taken vitamin C and shown what can happen as vitamin C is depleted in our body. If we have a good level of vitamin C is what tells our collagen molecules to cross-link, to do this so that they're nice and strong. You can see there's lots of collagen. This artery is nice and strong, it's nice and healthy. If we lose some vitamin C, now we don't have as many cross-links, and our blood vessels start to get weaker. We can see that now there's some weakness in the blood vessels, so our body tries to shore that weakness up by sending cholesterol, things of that sort to the area. Over time, we might overdo it, and that's where we start to plug up a little bit. If we get real weak, real nutrient depleted, now our blood vessels are kind of falling apart. Now we see blood leaking out of the blood vessel instead of plugging up. So this is the difference between an ischemic stroke and a hemorrhagic stroke. Ischemic stroke is we tried to overcorrect our weakness and we've cut off the blood supply to our brain. Hemorrhagic stroke is it just got so weak we couldn't do anything about it and we bled out of the arteries of our brain and we bleed into the brain. And that's, what is that? It's scurvy, right? So we have early scurvy and late scurvy, where the sailors would come across with no vitamin C and they'd fall apart. Does scurvy still exist? Yes. We see it a lot. So it was defined as having a certain level of vitamin C in your blood, and I would see it probably once a month in people in their blood levels. So it definitely still exists. proBNP, this is another thing that you can have measured. This becomes more important with congestive heart failure. What this little guy does is it's a natriuretic peptide, so it regulates fluid and sodium and potassium levels in the bloodstream. Elevated levels are often seen in patients with congestive heart failure or those with a decreased ejection fraction, meaning that their heart's not pumping as strongly as it should. They're not ejecting as much blood as they should. Again, they have different they have different risk factors depending on age. Why is this important? If you have an elevated proBNP, that's a likelihood that your left ventricle of your heart, the pumping force in your heart, is not doing its job. And for every increase, every 20 to 30 points that this number increases, it's associated with an incremental increased risk for death from cardiovascular disease. If it's greater than 450, even in patients who thought they had stable heart disease, it increases your risk 2 to 6-fold from dying from that heart disease. So it's a real important number. This is where I get to my patient about a year ago. It was about a year ago. His wife had this test, and it really helped her to get her lipids under control and blood sugar. So she finally pulled her husband in, and he came reluctantly, but he did come. And one of those farmers that the wife had noticed, he used to get up early. He used to have no problem feeding the cows. Now he doesn't want to get up as early. Now he gripes if he has to go feed the cows. Just his energy slowly declined. She noticed it more than he did. When he came to me, he was pretty visibly pale, so kind of thought, this guy's probably anemic, something along those lines. When we did his heart test, his levels here were off the chart. They were greater than what they could measure, so he exceeded the threshold. And that told me he's probably in congestive heart failure, and his ventricle's not working, so he's in some trouble. And then his LpPLA₂ was also off the chart, which told me he's severely plaquing. So he's one of those that I've only done, I don't do this very often, but I said, okay, you're going out the door to the ER, and let's get a heart cath on you right now. And he did, and he ended up having a quadruple bypass within that week, because he was 99.5% plugged in 4 of his major blood vessels. I don't know how this guy was walking around. Farmers are tough, aren't they? I don't know how he was walking around. Anyway, he came back, saw him after that. He's got color, and now he's going to work on things to keep that from coming back. As I say, when you have a bypass, you treat a patch of the highway, right? But you don't treat the whole highway. So we want to treat the whole highway now, and not just the patch. When we look, the reason this number is important also is because it tells us there's some sort of ventricular dysfunction. And that can lead me to say, let's go get an echocardiogram to tell us how much your heart is actually pumping. And to be a true candidate for bypass, your heart has to be pumping less than 30% of its max. So if your ejection fraction is under 30%, that's where I'd say you're not a bad candidate for bypass at this point, unless you want to do major chelation, things of that sort. If your heart is greater, if your ejection fraction is greater than 30%, you're not a great candidate for bypass, and you can get by with mostly natural things and won't have to do that. 70 to 80% of all bypasses are done when the ejection fraction is greater than 30%. So we could get away with a lot less of those if we actually looked at this number and looked at the ejection fraction. Again, usually if you see this high, then that's going to say we need to go get other things looked at. So whenever this number is really high, you're going to get sent somewhere to get things looked at further. Homocysteine, that's become a little more popular. Who's heard of that? So again, that's a toxic metabolite that can build up in the lining of the arteries. It comes if you have a disordered metabolism of sulfur in your body and you eat meat. So it's a toxic metabolite, builds up in the lining of the arteries. You're at high risk if it's greater than 15. We call that high homocysteine. High homocysteine puts you at increased risk for heart disease of all kinds, increased risk of cerebrovascular disease of all kinds, and increased risk for PAD or peripheral vascular disease. Also increased risk for osteoporosis and all kinds of other things. If you're at high risk, then we know you have a genetic requirement for more of certain B vitamins than the average person. So it's a simple treatment, more B12, more folate, more B6, more B2, and more, if it's really bad, we may say you need to do B vitamin injections. If it's borderline, we may just say take like a multiple B complex, and if it's normal, then you're okay. But homocysteine can be a problem. I had a patient who was told he had frontotemporal dementia, which basically was told he was going to go crazy within 6 months from diagnosis. He was age 55. He'd go crazy. They said, by the time this is finished, you'll probably be put in an institution because you'll be so mean that nobody will want to be around you. And really, this guy was at the top of his game as an insurance salesman. He'd lived all over the country in major cities. Everywhere he went, he got the numbers up at the corporation that he was at. He moved to Wichita and slowly noticed that his executive functioning skills were declining. He couldn't remember things with his clients. He just felt forgetful. So he finally just said, I'm going to take a leave of absence, try to go get this figured out. They ran all kinds of tests. He ends up going to a special psychiatric institute, and basically frontotemporal dementia can only be diagnosed after autopsy. So it's a clinical diagnosis. There's no lab test that can definitively tell you that you have that. A lot of times I think it's an error of omission, meaning we did not test one of the right things to tell you, what's actually going on. When he came in, I said, you've got nothing to lose and you've got money, so let's just run every test we can, or else you're just going to go downhill and give up. So he ended up having low thyroid, which when I looked through his labs, he'd had it 3 years prior, and they didn't treat him for it. So that was one thing, but his homocysteine levels were off the chart. So homocysteine can affect your heart, it affects your brain, all those good things. We did aggressive B vitamin injections on him, and this is 2 years later, and he's doing fine. He was supposed to be dead in 6 months. But now his functioning level, he comes in and he tells my nurses their first and last name, just to make sure we know that his memory's working. He calls all the receptionists by first and last name, and if he sees patients that he met the time before, he makes sure he knows their names too. So it's pretty impressive. He's got this high level functioning back, and so it's nice to see the guy that he used to be. I can see that now. When he first started at our clinic, he was sitting in the waiting room one day, and the receptionist, I don't make it a habit to tell them why patients are there, so we don't want crosstalk. He was sitting in the waiting room, a little kid was sitting with his mom, just kind of reading a book, and the kid wasn't misbehaving like some of these kids can do. He was being pretty good. I don't know what kind of noise the kid was making, but he told the mom if that kid didn't shut up, he was going to take him out and shut him up for her. And the receptionist come back, oh, this guy. I said, well, his brain's not working. So we put him in a room every time he had an IV or whatever, so he wouldn't get too mad at people. But now he jokes with everybody. I mean, his personality is just, he would light up a room. But at that time, he sat slumped and yelled at everybody. So it's amazing what high homocysteine can do. It's a real important thing to have measured. And if you know that's high, then just genetically, you need more B vitamins. Again, we look at your blood sugars. A1C is a marker that tells us what your blood sugar has done over the last 3 months. That is something that's pretty commonly tested. Insulin is one that not everybody has measured, but they probably should. That's the hormone that tells your body how to take in sugar. So it regulates our blood glucose. What we're really worried about is if it's high, unless you're a type 1 diabetic and it's low, or you've had type 2 and you've let it go on too long, and then you need insulin shots. Otherwise, we're wondering, is your insulin high? Why do you want to do this test? One, it tells us if your cells are resistant to insulin, meaning they're not responding to that hormone. It can help us, look for tumors that are making too much insulin. But it really tells us, if you're a type 2 diabetic, it also helps us decide if you need insulin therapy or if we can still work with you through diet and nutrients. If we find that you have insulin resistance, that does increase your risk for developing heart disease and stroke. Why would you measure fasting insulin? Because insulin goes up long before your sugars become abnormal. It's a much better test than measuring blood sugar because it's going to go up way before your blood sugars become bad. As many as 50% of people who have high insulin are of normal weight, so you can't just say it's only for fat people. It's also in skinny people. So we can find that all the time. High insulin can cause low blood sugar, but eventually it's going to lead to high blood sugar. So if you have high insulin, it may start off as low blood sugar symptoms. It's going to lead to diabetes down the road. So if you feel shaky and you need caffeine, things of that sort to get you going, you may have some blood sugar instability. What does high insulin do? It stimulates inflammation in our body. It raises all these little inflammatory chemicals. So it increases the risk of degenerative diseases, especially heart disease. It stimulates the production of cholesterol in our body, so it actually tells our liver to make more cholesterol. It lowers our HDL and raises our bad cholesterol and our triglycerides. It messes with the lining of our arteries, so endothelial dysfunction. It increases clotting. It raises our fibrinogen just by having elevated insulin. And that all leads to cardiovascular disease. If you can get your insulin normal, a lot of times you can normalize your cholesterol, decrease your clotting factors, all those good things. Insulin promotes storage of fat, blocks the breakdown of fat, increases fat basically everywhere. It can raise sodium. If we raise sodium, then it can raise our blood pressure. So it does a lot of bad things. And that's, you've heard of metabolic syndrome or syndrome X, that name's been out there forever. Basically, all you have to do to diagnose that is if you have normal blood sugars but high insulin, I'd say you have that. And it's characterized by insulin resistance. So insulin resistance, again, causes all the bad guys to go up, causes their blood pressure to go up, can eventually cause blood sugar to go up, makes our blood more thick, all those bad things. If you have high insulin, you're at a 360% more likely, you're 360% more likely to die from heart disease than those who do not have high insulin. So we want to get that insulin level down. Again, metabolic syndrome would be if your waist was bigger than it should be, if your triglycerides were higher than they should be, if your HDL was too low, and your blood pressure was just slightly high, just 130/85. Fasting glucose over 100, that's the old way to test it. The new way is just measure your insulin. Measure your insulin and you know if you're setting yourself up for that, because the old way said you had to be fat. The new way says no, skinny people get it too. So skinny people get heart disease. Insulin resistance, again, we can do that test where we just take a fasting glucose and we take your insulin levels, and then they do a calculus method, and it gives us a score. And you want to be below 2. You don't want to be above 3. So if you have insulin resistance, you have a high risk for developing heart disease, stroke, peripheral vascular disease, diabetes, and high blood pressure. Also elevated lipids. So that's a great test to have at any time. I think people should actually start that in their 30s. Just to make sure how much your insulin is doing, then you can prevent your likelihood of developing other bad things down the line. Again, diet does help that. Weight-bearing exercises, doing things like lipoic acid can be helpful as well. Now, if we know that your blood sugars or insulin are high, we're going to look for this. So a lot of times, if those come back, the lab goes ahead.
The library will be closing in 15 minutes. Please finish up your task and bring any items to be checked out to the circulation.
Okay, we're going to put this adnopectin.
Children, if you need a ride, now is the time to call.
Anybody need a call? Okay. This is a hormone that is made by our fat cells that protects us against developing heart disease and diabetes. If you find that you have low levels of this, it increases your risk for diabetes and for heart disease. So you want high levels of that because it's protective. If your fat cells are doing their job, they should be protecting you. If they're not doing their job, then they're not going to make very much of this, and we give the numbers there for that. Again, GSP, glycated serum protein, that's something you can have measured. Let's say hemoglobin A1C, that gives us an idea of what your blood sugar is doing on average for the past 3 or 4 months. This little guy doesn't let you cheat for just a month. So let's say you did good for 2 months and went to your doctor after you had a bad month, but you had 2 good months. That A1C might look pretty decent. Well, now we can check this just in a month. So we can check this every month, and if you've been bad, then we can see it. So if you have elevated glycated serum protein, it tells us that you're at increased risk for diabetes also. So you can measure your glucose, that tells you what's going on that day. You can measure this, which tells you what's going on for 1 month, or you can measure A1C, which tells you what's going on for the past 3 or 4 months. So we're finding better ways to not let you cheat, right? Okay, APO, the other thing is you can look at your genetics. ApoE is a gene that's associated with heart disease. It's important because ApoE is what helps us absorb cholesterol. It's what helps us take in triglycerides. It also has an effect on our brain function. There's 3 different types of this ApoE. E2 is the least common. E3 is the most common. And E4 is the second most common. E2 is the most protective for preventing our risk for developing dementia and heart disease, so protecting our brain and our heart. E3 is average, so you're just like everybody else. You're probably going to get something. And E4 is, uh-oh, you better really watch what you're doing, because mom and dad probably gave you something bad. You're just an accident waiting to happen. So ApoE genotype. The E3 is the normal form, so it's just associated with average risk. E4 is associated with increased risk. Why? Because if you have E4, you absorb more cholesterol than the average bear. So every time you eat, you suck all that cholesterol in, more so than the guy sitting beside you, okay? So E4 just helps you get more cholesterol. Also, helps your liver make more cholesterol and LDL, so you have a higher risk of developing cardiovascular disease and a higher risk of having dementia. Whereas E2 tells your intestines not to suck up all that cholesterol from your food. So it's more protective. You have lower total cholesterol and LDL with that. Other gene, again, would be the same therapies that we kind of talked about that help your lipids. Two other genes that are important, especially if you travel, drive trucks, or fly on airplanes, is factor V. It's a protein that increases clot formation in your body. If you have that, you know that you need to definitely drink water, move your body when you fly or drive, stop every hour. So that's a great test to know. I did have a lady, we measured this after the fact because she wasn't my patient before, but she was 50 years old and had a heart attack. Lipids were really low, completely normal. She ended up having this. She had the factor V, so what got her was clots in her heart that caused her to have a heart attack. Now that we know that, we can treat that with things that will keep her blood thin. Again, prothrombin or factor II, that's another clotting factor. It's good to know because if you have that, there are natural things we can do to inhibit that enzyme. So again, it's good to know your numbers. As I say, knowledge is the power and can be life-saving if you know your true risk. So there's different variants on this, but a lot of the doctors' clinics will have something similar. We use the Boston Heart. The unique thing about that is you have to fast for 14 hours. Most tests we tell you 12. This one's 14 hours.